Summer's here. That means that it is time for anesthesiology trainees, RRNAs, residents to start out in the operating room for the first time. Yay! In this episode, we're going to talk about the top 3 things that the newbies need to know in order to be prepared for your first day in the operating room. Stick around until the end. We're going to drop our favorite resource for anesthesia trainees to use when they're in the operating room. Before we dive in, my name's Chrissy. I'm a CRNA. I've been practicing for 6 years. Before that, I was a CVICU nurse.
My name is Anna. I am now a second-year SRNA. I just finished semester 4, which is wild. And I was a travel nurse for 2 years, and I was a CVICU nurse for about a year and a half as well. And together we started Confident Care Academy. We provide this podcast, which is free educational resources for SRNAs, for travel nurses, ICU nurses. And then we also have a critical care membership for people who want in-depth deep dives into pharmacology, critical care, CRNA school prep. But I feel like that really leads into the burning questions that everyone has. Every SRNA or a resident wants to know, what is the first thing that we need to know on our first day in the operating room?
Okay, the most important, guys, I've been precepting RRNAs for 5 of my 6 years of practice now. I see a lot of you guys. I used to be a clinical coordinator at my old job as well. So I'm deeply familiar with the training process from baby bird until, kicking y'all out of the nest. The number one thing that I want from you guys on your first day in the OR is you have to know your medications. There is no shortcut around it. If you don't have it ready to go on day 1, I'm sorry, you can't touch the drugs. I can't let you do anything else. This is your whole job in anesthesia, is pharmacology. I need y'all to know your drugs down to the receptor site level, the indications for using it, the contraindications for using it, so who you're not going to use it on. I need you to know the appropriate dosages to give. I need to know that you know the concentration. So 1 ml is how many milligrams? These things you should know off the top of your head like that. There should be no pause. I should be able to open up the medication drawer, point to any medication in the Omnicell, and you should be able to spout off each one. And I know that sounds mean and scary, but it's literally your whole job.
So for day 1, do you expect your learners to have everything drawn up when you come in the room? Do you want to see us draw it up? What do you like from that perspective?
I think the majority of preceptors expect you to do as much as you can on your own without being excessively wasteful. So you should have an emergency airway set up, ready to go. You should have, if you know that it's going to be a general anesthesia case, or it's probably going to be a general anesthesia case, you can drop the basics. You can drop your propofol, your lidocaine, your paralytics. But I don't personally ask anyone to drop narcotics until, I don't even draw them up myself anymore until the patient's in the room. Cases get canceled, they get shuffled around. People want different things, and I don't personally like wasting. I think most preceptors would be okay with that. If you're not sure what kind of case we're doing, like you just really have no idea, I think it's appropriate to, again, do your machine check, do your airway setup, and then you can make like dry syringes. So you put the syringes with the needle on and just lock it in the top drawer. Maybe just don't, set everything up yet. Always have your emergency drugs prepared no matter what. So your phenylephrine, your ephedrine, if your facility does dilute epinephrine, your atropine, your epi, like have it all organized and ready to go.
Apples.
Apples?
Yeah.
Is that an acronym they gave you guys?
Yeah, atropine, phenylephrine, propofol, lidocaine, epinephrine, and sucks.
That's cute.
Apples.
Guys, I love acronyms. We're going to talk about all those in this episode. We got so many acronyms.
And probably the checklist manifesto. I feel like that's probably going to come up at some point. It always does.
The checklist manifesto, a collective bargain. We are responsible on this podcast for driving 98% of Amazon sales of those 2 books.
You should read them if you haven't read them already. You may or may not have Pyxis access yet on day one, right?
Okay,
so if you do have Pyxis access, you're saying, yes, draw up if you know what the case is, which you probably should because you're reading about the case going in before. Is there anything as far as airway setup and also labeling preferences? Because I know, we SRNAs, I'm preclinical. I shadow and I do a little bit clinically, but I'm not full-time clinical in the OR yet. do I ask whether you prefer your labels one way or another? What do you want from that perspective?
Okay, so as long as you have a reason and like a safety idea in mind, most people are okay with it. There's kind of like I guess I'll say three philosophies on syringe labeling, and the third one is wrong. So the first two I'll accept.
There's 2 opinions and 1 incorrect.
There's 3 opinions,
and
one is wrong. The other one I don't personally like, but I'll get over it if you do it.
See, this is what we want to know. We're this is like, how do I avoid the wrong one?
Don't do the wrong one.
Okay.
So
what's the wrong one?
The wrong one is when people, and it drives me so insane. And I'm nice about it, but inside I'm dying. So just know you're making me sad.
Well, we're all afraid. So continue.
Inside, don't make me sad. When people just slap the label on the syringe willy-nilly, and it's not lined up with anything. Like it's not lined up with the little lines and numbers, nor does it wrap circumferentially around the bottom of the syringe. It's just like
on there.
And when the syringe lays down, like you may or may not even see the sticker because it's just like diagonally slapped across the back. That drives me so wild because to me, that is such a safety concern. In an emergency, if I'm giving a break in your room and I want to go to grab an emergency medication and I don't see the label clearly and obviously, I'm not going to be able to grab it quickly. I might be scrambling to drop a new one. Someone else might have grabbed it. It might get given twice. Like, to me, that's a major safety concern. So, wrong answer.
I would agree that that's incorrect.
It's incorrect. And people do it all the time. Don't get me started. I'm already started. Option number 2, which I'll tolerate, is when people wrap it around the bottom of the syringe because then no matter which way the syringe is lying, you can always see the color and the colors typically correlate to the type of drug you're giving. Now, here's some reasons why I personally don't love it. One, it can be hard to read the actual name of the medication. It's like when it's wrapped around the base like that, especially on a tiny syringe, like a 3 ml syringe.
And also like the milligrams per, like it's hard to read.
It's hard to like label and write out the concentration. And then, drugs go in and out of formulary. There's shortages. Things get swapped in concentrations all the time. So I do think it's important to have that written out. If you work in pediatrics, you're giving really, really tiny doses and it's really important to be precise. So like, again, we really want to see things. Sometimes you don't have the labels available to like put the correct color on. So now your epinephrine is being labeled with like
a white
silk tape or a white sticker and it's not going to stand out to you as epinephrine. So that's like an acceptable option, but to me, it's not quite as safe as option, my favorite option, which is I like to lay out the label, along the same axis as the syringe. So it's vertically, I guess we can say. And actually, we'll put up a picture here. I took a picture of it for you guys. It's because I'm so anal about this.
Yeah, you're very anesthesia.
It's like I can't help it, but people love it. Anyway, so you overlap it with the little lines just a tiny bit so that whenever anybody is pushing the medication, they are forced to read the label. You can read it out, epinephrine and the concentration right there. So as you're pushing 1 ml at a time or 0.1 mLs at a time, you can always be reading it. And to me, that is like, there's no way around it. Like that's like obviously the safest choice.
Do you feel like that feeds into kind of safety checks for RRNAs as they're learning too? Like because you are forced to look at the concentration and the dose every time that you're pushing.
Yeah, it reinforces that knowledge.
It's a big transition, right? From like you're working in the ICU and then like you're looking at orders and you're like scanning everything.
Oh my God, the barcode scanners, guys.
The barcode scanners, yeah. Like,
guys,
do you want to talk about that a little bit?
So this one kills me. And this is something that CRNAs talk about all the time because it kills all of us because we're all old. So none of us grew up in the era of barcode scanners. And like everyone who's now coming through school, like has pretty much exclusively worked with barcode scanners. You don't have barcode scanners in the OR anymore, guys. Like it is no longer acceptable to just like grab a vial out of the Pyxis and like scan it and then just draw it up and give it without really paying attention and hoping that the computer catches your mistake, right? First of all, that was never the right way to do it. That's part of the reason why Radon Devat, had her error is because there was no barcode scanner available to her. That lack of vigilance in truly reading the label is what got her in trouble with giving vecuronium to a patient instead of Versed. But, in the OR, you're not going to have that safety check or balance there. So it's important for you to do your 5 rights. It's important for you to read the vial. As you're drawing up medications, one little safety tip I do, I like to call it, I dummy proof everything. I dummy proof everything in my OR. Like, you cannot walk into my room and mess up because it's dummy proofed. And I do this for myself too, because on 24-hour calls, when you've been awake for 24 hours straight at 6 a.m., when you get your next emergency C-section or your stat trauma that just came in, your brain is not at 100% capacity. It's easy to make these errors. So we're going to dummy proof everything for ourselves. Only draw up 1 vial at a time. So I pull out all my vials at once and I put them in my top drawer. And then I take out 1 vial at a time on top of my Omnicell and 1 syringe at a time. I look at the vial, I label the syringe, I draw it up, I read the vial again, and I throw it away. And I actually say it out loud to myself.
Mm-hmm.
I'll say, Odancitron,
4 milligrams.
4 milligrams. And it's like, and then I look at the concentration because the concentrations change. Typically not for Zofran, but our dexamethasone concentrations change all the time. Sometimes it's 10 milligrams per ml. Sometimes it's 4 milligrams per ml. So like, how much steroid am I giving?
Do you prep your syringes before and then pull all your meds out at the same time and then you just throw away each vial as you draw up the med, or do you keep it like very separate? This is kind of like a very niche question.
Matters. You can either do all your syringes first and pull out all your vials first. That's fine. As long as you're only having 1 vial and 1 syringe out on top of the Omnicell at a time while you're doing it. That way you don't accidentally swap them. In fact, I did it the other day. I broke my own rule the other day. Mm-hmm. I was drawing up fentanyl and Versed at the same time. And I was talking to someone. Mm-hmm. And so I drew up the fentanyl in the midazolam syringe. And then I went to throw away the empty fentanyl vial. And then I threw away a full midazolam vial. I just threw it in the trash. I had to get the OR nurse to waste with me. And I was like, I broke my own rule. If I had only had 1 syringe and 1 vial out at a time, I wouldn't have had to do it. So I had to waste all the drugs and start over. I was like, I can't believe I just did that.
I'm still, again, I haven't started official clinical yet. I do shadow and I pull up meds and I'll intubate now, but it's not my case yet. And then I was just thinking about this the other day. I had drawn up all the meds for the next case, and then I had thrown out everything except for the empty fentanyl vial because I still have like that kind of ICU nurse mindset of like, I want my preceptor to see that I'm not throwing away fentanyl. I want them to see that it's in the syringe and that the syringe is full and then that the fentanyl is empty.
I actually think that's a good practice to keep.
Okay, cool.
And there are some preceptors who will tell you to keep all of your empties because in the case of like an emergency,
they want to see what's been used.
They want to see what's been used or not used. So like,
that makes
sense. Did you push the wrong drug by mistake? You have like your evidence there that you had the right vial. So I actually think that's okay. You don't have to throw away your vials when you're done. You can keep them in a little pile in the corner, but put them away, right? So like, you're only drawing up 1 vial and 1 syringe at a time.
Separate by space. So you have like your empties in one corner and then your new med that you're pulling up is the only med that's right there.
Well, the new med is always on top, right? Okay. We're never doing it in the drawer. You're doing it on top. So it's out in the open. Everyone can see what you're doing. The vial is on top. The labeled syringe is on top.
Okay.
When you're done with that, you put it in the drawer. And so then you do the next one on top.
Okay.
That way it's like so separate. You cannot mess it up.
I like that. And so far, all of my experience has been in like outpatient, either plastics or orthopedic surgery places. So I haven't been in main ORs for pulling up drugs and cases. So it's very interesting. I'm like mentally taking notes like as Chrissy's talking here.
Yeah, it's good.
So what do you mean when you mean like know your medications inside and out? Like, is this just pulling from like Nagelhout specifically? Is there places where you like really, you want your students reading from as you're asking these questions, or as people are like looking to go to CRNA school, like how can they start prepping ahead?
Well, so it doesn't matter what program you're in. You're never in the OR your first semester. Yeah. Even in the integrated programs, usually you have a semester of basics of anesthesia before you hit the OR. So you have already gotten lectures on pharmacology of the inhalational anesthetics, of all of your induction medications and all of your emergency drugs. And as an ICU nurse, you should know most of these emergency drugs already because you're using them on the unit, right? So I don't care where you do your reading. In fact, most of you are going to have to pull from several sources because a lot of the anesthesia textbooks, they're so focused on teaching you like, the overall picture of anesthesia, they're really not great resources for pharmacology. You really need to go to a pharmacology textbook or pharmacology resources on the internet to get the in-depth of pharm. So right now, the only in-depth pharmacology textbook for anesthesia is by Stolting.
Mm-hmm. I like Stolting.
I actually know, I have a little secret that I
know Stolting.
No, I don't know Stolting, but I do know of some nurse anesthetists who are currently in the process of writing another pharmacology textbook that's going to be even better for anesthesia. Because I know them both, and they're both really amazing teachers and experts on the subject. So
we'll continue to monitor on that. That's really cool.
Continue to monitor and assess. But you heard it here, folks. And it's not me. I didn't write it. But
this time, no textbook coming from Chrissy yet.
No textbook from Chrissy yet. I mean, that is why we do have the pharmacology library at Confident Care Academy, right? It's intended for ICU nurses. So far, we have all of the pressors. We have propofol. And we're going to
channel blockers. Yeah.
Calcium channel blockers, beta blockers. We're going to keep working our way through different drug classes as time goes on, and we'll be expanding into our anesthesia library in the fall. But, the bottom line is you just have to, again, know it down to the receptor site level. If I ask you about glycopyrrolate, I need you to be able to explain to me, what you're giving it for, who you're not giving it for. I need you to explain to me that it does not cross the blood-brain barrier because of its
pKa.
Because it's a quaternary amine.
Getting flashbacks from pharm right now.
Yeah. I need you to know it doesn't cross the blood-brain barrier. Why is that important? Because
pregnancy and also CNS alterations and also.
I'm thinking CNS alterations mainly because in older adults, we would want to avoid scopolamine because of confusion. But also I like to avoid in older adults anyway because they usually have some coronary artery disease and it usually causes more urinary retention for the older population than it will for younger people. But these are just important things you need to be able to spout out to me before you give any drug in the OR. So it sounds scary, it sounds mean, but it's the entire reason you're here. And you've had at least 1 to 2 semesters of preparation to get ready for this. So that is stuff that you can definitely handle on your first day. Whew. So Anna, you have had some experience in the OR now, which is so fun. I love hearing your little experiences, the things you get excited about. You forget the magic. So what was it like for you, finally getting to intubate for the first time?
So I think there's also this expectation that it's going to be the culmination of everything you've worked for and it's going to be incredible and you've looked forward to intubating for years and then you might miss it. I missed my first intubation and I missed my first LMA placement, both of them. But it is something that there's a bit more, it's a lot of finesse and it's skill, right? And it's not going to be, it's like placing your first IV. You may or may not hit it on the first time. So
you probably won't.
Probably
and that's
won't.
Okay.
And being kind to yourself with that, I now have successfully placed both an LMA and an ET tube. I used my McGrath for that. And then, I actually thought that LMAs were harder to place than an ET tube on my first time. Yeah. And Chrissy has kind of talked me through a lot of her skills and tips. It's the whole, as a student, you end up rocking and you need to lift. And then I feel like I need to be doing left-handed workouts all the time to lift more. Yeah. One arm deltoid because it's these patients, you're lifting their whole upper torso to almost, not quite, but it what it feels like as you're trying to get a view as you're placing. So I will say they expected me to be able to talk through the anatomy as I was going through. They wanted me to say what I was seeing and then talking through. So I was really grateful that we'd had all this kind of practice about communication with providers. And we also have a whole episode on provider communication, which is, I still think, relevant. We can do another episode for SRNA communication, what you want for us to be talking through as we are walking our way through a case. Because what do you want from us as we're as you're working with a new resident or a new RRNA, what do you want from us as we're placing the airway for the first time? Or just communication throughout the case, right?
Yeah, I do want to know what you're looking at. I do want to know what you're seeing. I think it's hard for people. It's actually a really big ask, and it's easier said than done. It's really hard when you're first learning to intubate. When someone says, "What do you see? What do you see?" to be able to say, there's pink. It's really...
I see tissue.
I see tissue. Okay, good, right? And that's... So even if you just say, "I see pink," we know that you're able to take a deep breath and get words out.
You're moving air, you're ventilating.
One thing I want you guys to be able to do is also slow down when you're doing these new skills. There's a lot of like tunnel vision and pressure and like, and like if you just listen to my words, I'm going to coach you through it and I am going to help you succeed in this moment. But I need you to stop and do what I'm saying. And that's a really, really hard thing to do. So, when somebody says
in real time,
it's in real time. So when somebody says pause or stop, just freeze right where you are. A lot of times they'll say stop and they'll be like, and I'm like,
don't pull back, just stop.
No, I just mean stop, right? You're like, you're doing the teeth. They're like, stay off the teeth. That's a big one. Stay off the teeth. That means stop.
I haven't dislodged anybody's teeth. All right.
Stay off the teeth. That means stop. And then listen, if I say like, okay, move your hand to the left, I want you to stop and look at your hand and actually move it to the left. That's such a hard thing for people to do when they're tunnel visioning. So know the anatomy ahead of time. Watch videos on YouTube. I actually have 3 intubation tip videos on TikTok where I do it on a sim dummy. Chrissy's CRNA on TikTok. I'll eventually, when I get around to it, do a full-length video on YouTube as well because I do think it's really worth diving into. I think not a lot of people are good at explaining the mechanics.
But she has it's saved in a playlist on TikTok, I'm pretty sure.
It's saved in my Anesthesia playlist. So it's easy to find if you just go to the top. But, really just paying attention to what you're doing, looking at the anatomy as you're going down and verbalizing it out loud. My blade is to the right of the tongue. I am moving my hand to the left. I don't see the vallecula yet. I'm going to advance. Okay, I think I'm too deep. I'm actually going to pull out. This is so helpful in helping us help you. That's all we really need from you. So whenever you're learning any new skill, it's so important to know the anatomy that you're working with. So in the case of airways and intubations, we have the tongue, we have the tonsils, we have the epiglottis, we have your uvula, we have your teeth, we have the hard palate, the soft palate. All of these things you need to be able to identify and verbalize. The vocal cords, of course, the arytenoids, which is really the corniculate
uniform. Yeah.
But everyone's going to call it the arytenoids. We need you to be able to say those words out loud and talk us through it. And it's going to help you also. It's the same thing for IVs, really understanding the anatomy of how veins and arteries work when you're going to place these lines is going to be really helpful for you actually succeeding rather than just like sticking a needle and hoping it works out.
Yeah, I feel like as a nurse, there's definitely the learning curve of as you're learning how to place IVs, you often are identifying what you think is the vein, and then you will, really kind of hope for the best. But I feel like there's this level of precision in anesthesia training that's really expected, which is great, but also it's a pretty big learning curve, like learning that anatomy inside and out and learning the anatomy externally and on imaging, right? So with POCUS and ultrasound, and I don't know if you have any tips about that, because like you place lines pretty frequently, right? You do some cardiac anesthesia as well. So that's something that for us is so intimidating, like you're learning like your external landmarks, then you're memorizing for an exam, but like seeing it and doing it in real life with that sort of like anatomical knowledge. I don't know. Do you have tips about line placement, anatomy, all that stuff?
It all just goes back to anatomy. I mean, understanding just what it looks like under the surface. So using those like 3D Atlas apps and programs, looking it up on YouTube, seeing as many images as you can, drawing it out as much as you can is going to be so helpful. It's also going to be really helpful for case preparation. So understanding the surgeries themselves and why we're doing the anesthetic that we're choosing is all based on the relevant anatomy in the area. So, most surgeries we could argue could be done multiple ways. Like you could do almost anything under MAC or local if someone gives enough local anesthesia in theory, right? You could do literally any procedure under general.
My brain just said the max dose of lidocaine and epi. Sorry, per kilogram.
That's great. We love that. But, if a procedure is happening near a high-risk structure, like, hey, they're likely to hit this really close by blood vessel, we're obviously going to do it under general anesthesia and place extra IVs and consider an arterial line for close blood pressure management and the ability to draw labs if we think this patient really might bleed. We're going to have blood on standby and or in the room, right? All of these things are going to be really different than the patient who's getting carpal tunnel surgery, which could be done
with
a block or just local infiltration at the site by the surgeon, plus or minus some sedation. So all of these things you're going to be able to predict what you need if you understand the anatomy. So is there a major blood vessel nearby? Are we doing laparoscopic surgery? And you have to know what happens how does laparoscopic surgery work? We insufflate carbon dioxide into the peritoneum. And what's that going to do? It's going to push on structures. It's going to cause hemodynamic changes. It's going to push on the stomach and make people vomit.
And the diaphragm. And
yeah, obviously we're not going to do that awake, right? Because you just think about what is all that pushing on? What's the anatomy happening there?
And I learned that we'll do most of those with an ET tube in general.
Yes.
For that reason, which kind of leads into you're talking about knowing your anatomy, knowing your ultrasound, knowing all of this as you're coming into your different cases. So let's say it's my first day in the operating room, which I'm still going to count my first day in the operating room in January as like my first day. I've been shadowing, but it's not been like my cases. How do you recommend that residents and RRNAs get familiar with the OR in general, the equipment, everything that's there? Because it's like a spaceship. It's a whole new world.
It's a spaceship. It's going to be just repetition. If you can get into a sim lab on your own time, I definitely recommend you do it. Or just as much time as you could spend in the operating room. If you're given the opportunity to shadow ahead, take it. Get there very early in the morning in the beginning to work your way through your setup. It's going to take you forever to do your machine checkout, to set up every single little thing. My little checklist in the morning is soap TIM, suction, oxygen, airway. Airway includes bougie and ambu bag, as well as my ET tube setup and all my blades, pharmacy, so all my drugs, tape. Definitely need tape for everything.
What do you have to say about tape, Chrissy?
I don't know. What do I have to say about tape?
Not to put it on the anesthesia machine.
Don't put it on the anesthesia machine. I hate that. It's so gross. It's so gross. There's so many better places to put your tape. Okay. Anyway.
Sidetrack.
Put the eye tape on the mask, and then you can put it on the patient, and it's on like their own clean surface, not like a yucky machine that someone's saliva is on. Like, ew. Anyway. Like we clean it, but like, I don't know. People miss a spot. It's gross. Tape IV, so your IV fluid's ready. Do you need extra IV equipment? Do you need like A-line setup, like whatever that entails? And then monitor. Turn your monitor on, make sure they're working, check your end tidal, all of those things. Again, making sure you really understand how all this equipment works, because when things go wrong, the need to troubleshoot is really important. So like yesterday, for example, I was in a cardiac anesthesia case, and it was like strange. I was inducing with this anesthesiologist, and I was mass ventilating the patient, and the patient was getting a lot of positive pressure built up in the circuit. And she was like, oh, make sure you're giving the patient enough time to exhale so we don't have too much positive pressure because it's affecting his blood pressure. I was like, I am ? But then like we were looking at the machine and we're like, why is the bag not emptying? And we flipped the patient over to the ventilator and the bag still wasn't emptying. And so we're like, is there a kink somewhere? It's alarming for high peak pressures. It turned out that the scavenger was somehow turned off. Oh. It was like somebody had like screwed it all the way closed. So none of the air in the circuit was escaping into the scavenger. So we fixed it. We figured it out right away. But like understanding your equipment is
how it works
so important for troubleshooting that, because it was directly affecting the patient's blood pressure. He couldn't handle the high peak. That also goes into, I used to always joke about this. I would call it like the HUP suction crisis, where like in our old building, we would have these suction canisters. I loved this job. This is the best job I ever had in my life. I'll never have a job this good again. But we had these old suction canisters in the old ORs that were like up high on the ceiling.
Christy's like 5'0" for those of you who don't know. She's a very tiny person. Continue.
And suction is really important in anesthesia. Like you have to be able to clear secretions from the airway on induction and stuff. So I used to always tell my students to make sure you put down an extra piece of tape to secure the side of the suction tubing to the canister, because if you're just relying on gravity and it wasn't screwed on tight enough, if you pull it quick, it could fall off the back when you're like inducing a patient. Like you emergently need the suction. You grab it quickly, and then now you don't have suction. So just put down some tape was like my little tip at the time. But also I've run into issues where someone else has set up my suction canister and they accidentally, and I never knew that this is how suction canisters worked until this day. They accidentally swapped the vacuum side, the part that connects the canister. So the tube that connects the canister to the wall suction, they put it on the patient port, and then they put the patient tubing on the middle port that's supposed to connect to the wall. Now, I always just assumed as long as as long as there's two holes hooked up to two hoses, it didn't matter. Well, that's actually not true about suction canisters. And I will show you guys a picture here. That middle port that says that it's supposed to go to vacuum has a filter on it. So that when like little gunk gets sucked up, it doesn't go into the wall unit. So once that filter gets clogged so if you swap the tubing and gunk is coming in from the patient's side. So so initially if you have the two hooked up, it will work. So before this case happened, I opened up my suction. I listened for the hiss. I said, great, my suction's working. I was in the GI suite. I suctioned the back of my patient's airway. As soon as saliva went through the tube and went into the canister, it immediately clogged up the filter and it couldn't suction anymore.
Oh.
It's because it's a one-way filter. It'll get clogged. So this is why it's so important to know the anatomy of your equipment. Those little things are actually major safety concerns. So thankfully the patient was okay. It wasn't a big deal. Actually the endoscopy nurse figured it out immediately and swapped the lid on my canister and fixed it in a second and the patient was fine. But if that patient was having a major aspiration event, God forbid, that would have been a big problem. So it's really, again, important to be able to troubleshoot in real time by setting up ahead, really looking at equipment, really understanding anything before you use it, really understand how to use your blades, really understand how to, stylet endotracheal tubes properly so that you don't give your patient a tracheal laceration. Don't put it in too far. Don't put the stylet into the trachea. Those little things.
Do you use lube at the end of your stylet?
It's not necessary. It is helpful.
When I pull it out.
When I have lube, I do it so that it's easier for the person pulling it out. Or if I'm pulling it out myself, it's easy for me to take out.
Somebody will usually pull out your stylet?
Yeah, you can say stylet and somebody will.
Ooh, that's fancy. I like that.
Yeah, that happens in 99% of operating rooms across the country.
Oh. See, and I'm
usually
learning,
your circulator will do it for you.
Pull it. Because then
yeah.
As I'm learning and I have my blade and then tube and then it's okay, well, how do I get my stylet out?
And then stylet. Okay.
And then connect
I have
to
a trick.
Okay, yes, I'm ready for the tricks.
So at the end of your stylet, I make a little bend in it so that it's 90 degrees. And by the way, when you're intubating, always hold the endotracheal tube towards the very, very top. Do not hold towards the mouth. Everybody wants to hold towards the mouth because they think it gives them more control. It actually gives you less control because you think of your hand as the fulcrum on a lever or the middle of a seesaw.
So it's less.
You actually get less leverage and less range of motion when you hold too close to the mouth. But if you hold all the way back with just the tiniest bit of motion, you can actually get a much wider range for your tube.
Me thinking, this is physics happening in my mind right now.
It's physics. It is. Anesthesia is all physics. It's all physics and chemistry. But, and I promise you guys, try it and you'll see. You'll be oh. So your hand's going to be at the top anyway. Make a little loop with the top of your stylet. A lot of them come with a loop on them already. But if it doesn't, make a loop. And bend it to the right like this so that when you're just get the tip of your tube through the vocal cords, pop the top like a soda can, like this, literally pop the top. This is not sponsored by Bubbly.
You're open to that.
You're going to pop the top with your thumb. And then now the stylet is no longer in the trachea. You can advance your tube another centimeter. And then once the balloon is through the cords, then you're just going to, take out your blade, hold your tube, and pull your stylet out the rest of the way.
I love it.
It's so smooth. You look so cool when you do it.
So I'm thinking about the stylets that I've used, and they do have the little kink on the side.
Bend at 90 degrees.
And as it's bent on 90 degrees, and then my instructors have said to do that, right? So I'll have blade in this hand, and then once I'm in, and then anatomically right, they'll say pop it with the thumb. And then because I'm doing the stylet myself, then the blade will come out and then the stylet will come out.
That's good.
With the left hand and then connect with the right hand. It's so much, it's patting your head and rubbing it's the whole
So put your blade down, then hold the tube with your left hand, pull out the stylet with your right hand, and then hook up with the circuit.
Yeah.
And the circuit, and also it's okay to let go of the endotracheal tube once the balloon is inflated.
Okay.
So actually you're going to take out the stylet, you're going to inflate the balloon, then you're going to let go, and then you can connect your circuit.
And then
it's not going anywhere. If the balloon is up, it's not going anywhere.
So I think also for us learners, I'm coming into the operating room with the energy of every intubation as an RSI because that's what I've seen on the ICU.
So it's still true in an RSI.
which is true. But what I'm saying is more that like, I feel that everything has to be done within like 15 seconds because the patient's about to crash. And for
But
a
it
normal
is still
induction,
being done in 15 seconds.
you are. But also what I'm saying more is like if you do pre-oxygenate, which you always are, you have longer than 5 seconds to do the whole thing. Like I think there's this massive sense of urgency of like, oh my gosh, I have to do this right now because you come in, if you're an ICU nurse, you've been coming from a place where like if you're intubating in the ICU, it's usually because they're about to code or there's something happening, and scheduled surgery is usually not a code blue type of situation.
Yeah, we've pre-oxygenated for
your 2 minutes,
Yeah, and you have washed out all of their FRC. They're
denitrogenated.
You've denitrogenated their lungs, their functional residual capacity, which is the volume in the lungs left over after the end exhalation of normal tidal volume breathing.
See, I am learning things.
Yep.
Look at me.
Now, they've had a 20% decrease because they're supine. So that's why you should technically pre-oxygenate with them ramped up or sitting up. But this is advanced. We'll get into that in another episode. But yeah, your patient really should be supine, sitting up, pre-oxygenating. I don't drop the bed until after they're anesthetized. Then I drop the back down.
Smart. I like that.
We keep as much FRC in there as we can. We wash out as much of the nitrogen as we can. We make sure our end tidal oxygen is like at least 80%. I like it to be above 90.
Mm-hmm.
And then you have, in theory, if the patient is healthy, 10 minutes of apneic time before they're going to deset. In real life, I feel like most people, it's closer to 5, but still, that's a lot of time. Even in the ICU, though, when I'm doing RSIs on the floor or the ICU, you still shouldn't rush. Like, I know there's like that sense of needing to rush, but the patient is already sick. You can only make them better. Causing airway trauma or having multiple attempts at intubating is going to cause more swelling in the airway and make it harder to achieve success on your second attempt. So it's important to still slow down, take a deep breath, and do it right. Multiple intubations is like one of the highest indicators for a failed intubation. So if you really want to, save your patient.
Just like previous nausea vomiting is the highest indicator for post-op nausea vomiting. Anyway, sorry.
No, it's true. It's true.
So then with your few minutes of apneic time, you have your monitors, you have your equipment. What are some ways that you like expect your learners to know like how equipment works? Like, so let's say you've got a resident, an SRNA, or like a shadowing ICU nurse. Like, what do you expect from them in terms of like how the equipment works? Are we talking Beer-Lambert law? Are we talking about how the pulse ox work? How does the pulse ox work, by the way?
Depends on how mean I feel that day.
Has Chrissy had her coffee yet or not?
Depends on if you prepared for your case or not. If I think that a student has really put in the work and is really trying and is a good communicator and like they came in early, they set up everything, they like did stuff ahead of time, they verbalize things when they don't understand them honestly, then I'm very, very chill with the types of questions I ask. Like, I usually just like to talk about situations and like, okay, what would you do if this emergency happened? Like, what are some other things we can think about? And I'll kind of like let them talk their way through a scenario. And it's like non-judgmental. But if I feel like someone's really not prepared, I might get into more specific types of questions because I'm trying to assess their level of knowledge and readiness to be there. And it's not to be mean or cruel, and I don't do it in a mean way, but it is important for safety. Like, I need to know if you're okay to be in the room right now. Like, do you need to step out and like go read some more and come back? That's fine if that's the case, but can you be taking care of this patient if you don't know how this drug works or this equipment works? So I need to know that you know how to do that. I think it's important for y'all to know how the anesthesia machine works. It's important to know any equipment that you're using, how it works. It's important, again, for the drugs. If you have questions about something new, like how does the cell saver work? Great. How does the heart and lung bypass machine work? Great. Those are reasonable questions. And you should have questions and you should be asking. But anything that you're using every day, you should at least know the basics. If you forget the Beer-Lambert law, I really don't care. But you should understand that your pulse ox is your most important monitor and why. You should understand tone modulation, meaning that the pitch of the pulse ox is paired to a numeric oxygen saturation. And when I have new students in the OR, I do often ask them to like close their eyes and guess the sat. Be like, play that little game.
Oh, that's cool.
Yeah. So, or like if the sat changed really quick, I'll be like, okay, close your eyes. Tell me what just changed. like I want them to start to get used to being one with the monitor.
That's so interesting. So if you're an ICU nurse and you have anesthesia aspirations too, right? Like you're also using the pulse ox, you're using arterial invasive monitoring, swan gates, catheters, all of that. We do have a whole lecture on how the pulse ox works in Competent Care Academy. It's in the monitoring and hemodynamics lecture. We'll show a little clip of it on screen as we're talking about this now. And that really circles back to that spirit of being inquisitive and to be asking those questions and going into that deep level, right? Because you're going to carry that with you, whether you're in the ICU or you're in the OR, and you really need to know how things work so that you can be the person who's going to know how to troubleshoot, right? Like you were talking about that suction incident. We need to know how all of our equipment works so that we're going to be the ones who are going to troubleshoot and like figure everything out at the end of the day.
Yeah, especially if you have aspirations to go into like more independent practice, or even if you're just in a big center that's under resourced, you're not always going to have an anesthesia tech available to help you. You're not always going to have an anesthesiologist who's free to help you, or another CRNA who's free, depending on the type of practice environment you're in. So it's really important to be able to do everything yourself.
That's been interesting watching and shadowing in particularly the outpatient plastics world. And my faculty who I shadow has showed me a little bit about what the supplying of an OR looks like, because when you're doing independent anesthesia, like you're ordering your own medications, you're ordering all of your own supplies. What does that look like as you're stocking an OR essentially? Like how are you making sure that you're staying ahead on all your supplies so that you're going to have what you need, not this week, but 2 weeks from now? And that sort of thinking ahead, I think, is really interesting to see, like kind of the supply and resourcing side of things as well. Like, okay, how many new cases of suction do I need? How much more fentanyl do I need? How much more like, Zofran? How much do I need of like all of these different things? So that's been kind of interesting to see as well. So as I'm entering into clinical starting in just a few months now, one more semester and I'm out there, what are kind of like point of care references that you like to see students using?
Oh, you know what? Before I tell you that, I think I want to make a disclaimer. I don't want to scare you guys. I don't expect y'all to be an expert in every single little thing on day one.
Yeah.
But I do expect you to get there early and try to work your way through things. So, I used to get to the OR at 5 a.m. when I was brand new to clinical, and then eventually became 5:30, and then eventually became 6, right? But I'd get there early. I'd go through all the equipment, and anytime I like ran into an issue, I'd write it down. Equipment that was missing, I didn't know how to find, like drugs that like I wasn't familiar with yet. And again, like, hey, like I've never seen this type of anesthesia machine before. I've only practiced on the other type. I don't know how to do the checkout. Like those types of things, write them down and then have them for your preceptor in the morning. Like I did all these things. These are where I got hung up. Like that's what I need you guys to do.
Well, I think we have another episode talking about communication and
provider communication.
Check out that episode. So you want for us as learners to show that, hey, we got here early. We tried to do the machine check, but it's a new type of machine. We haven't seen that. And we went to see the patient in pre-op if that's something that was an expectation that was set. Like try to see the patient in pre-op, get your IV, make sure the consents are in place and all of that stuff. And then if there's issues, I think getting there early is really helpful to talk to, the front desk to figure out what rooms you're in. Hopefully you find out the night before. But if it's like first day,
yeah.
Figuring out badge access, scrubs, where to go, all of that good stuff so that you like know where you're supposed to be in the morning, right?
Yeah. I actually made a little ebook, Your First Day in the Operating Room.
Check that out.
I believe it's in the Competent Care Academy membership. If not, I will put it there. I know that my shadowing guide is there, but
the shadowing guide is in the membership.
Both in the membership? I don't remember, but I'll put it there if not. But yeah, back to our resource. My favorite resource for people to use in the OR is Vargo. This is not sponsored by Vargo. We just love them. They have 2 apps, the Vargo Mega app and the Coexisting Diseases app. It's not comprehensive enough for you guys to write your care plans. Like you do have to do a deeper dive when reading before clinical. But if you're on call and a case gets thrown to your room that you're not familiar with, it has a nice cheat sheet there that's going to help you get through it. I still use it when I haven't done certain cases in a while. I'll be like, like, how did I used to run like that ketamine again for like this specific protocol? And then like, oh, I remember that Vargo like did it the same way that like this one ERES protocol did. So I pull it up in Vargo. All of the like The drugs are in there. There's a pediatrics table, which is great because I now do some pediatric anesthesia and I haven't done that in years. So
Right.
I love their peds table. It's really helpful.
And as I'm new in using it, I use it a lot just to poke around to kind of pretend that I'm going in to do cases, right? So then I can pull up an 85 kilogram adult male, general anesthesia tab. So then it'll show me, okay, this is probably the ET tube size you're going to use, or the LMA size you're going to use, and then all the medications, the doses according to that. So it's interesting to see, like, okay, well, like, and then this is a pediatric patient. Okay, this is the emergency doses for that, because, like, again, we're like so new early on. I wouldn't know immediately a semester ago what size ET tube I would use for like a 6-year-old, like all that stuff is like so new, just like the equipment itself.
Yeah.
It's a really helpful resource. Again, not sponsored, but it's really, I think, helpful for learners. And it sounds like people still use it as they're like establishing their practice as well.
Yeah. I mean, for adults, we're not really using like drug tables and sizing anymore because it's all kind of the same across the board for adults.
Right.
But it is helpful again for like the, how does this case work? Or, oh, I forget about this comorbidity and like all the anesthetic implications. Like rheumatoid arthritis, for example, has a myriad of anesthetic implications, something that you wouldn't necessarily realize as, like an ICU nurse or someone who's not an anesthesia. You wouldn't realize there's so many anesthetic considerations for those patients. Or patients with multiple sclerosis, for example, like these are comorbidities that have like lots of things that are really important for us to consider, and we can do episodes on that later too. But definitely check that out. Check out Vargo, both apps. It's worth the investment, guys. I cannot emphasize this enough. Investing in yourself when it comes to education, it's the number one return on investment you'll ever get in your life. It is so important to spend money on things like that, things like an app that's going to help you succeed in the operating room, or an educational program, as opposed to spending your money other places. I really do believe in investing in yourself. Same thing with like exercise. Like if your gym membership's expensive, like I think that's worth it. So be it. Anytime it's about like your health, your mental health, your physical health, or your education, you're going to get that return on investment for years to come. And
the whole rest of your life, because you only get one, you get one brain, you get one body. Invest in that brain and invest in that body. And also even other aspects, housing, relationships, all of that stuff is amazing, but at the end of the day, it's you. So invest in yourself.
Yeah.
So come back and please like the podcast. Please give us a 5-star rating. It helps us out a lot. Comment what you would like to see from us next time.
See you there.
See ya.